Excuse me. Okay, thank you, everyone. Today is the last session, session 4 of our role of health centers to provide primary care for justice-involved individuals. And this session will be focused on promising practices to support justice-involved individuals. A few housekeeping items. You're all muted upon entry. This is an engaging conversation, so if you have anything you'd like to contribute or any questions, please put it in the chat. You are able to unmute yourself, so just raise your hand and let us know when you have something to say. And the slides and recording link will be sent to you after this presentation in an email. So the National Center for Health and Public Housing is funded by HRSA, but the content of these slides do not necessarily are not endorsed by HRSA or the US government. And today our speaker is Dr. Kevin Lombardi. This is his background.
It's not
And
important.
very important. But he has been leading the past 3 sessions and will now be concluding today. So, and I am Olajumoke Oladipo, or Jumoke. I am the Health Communications and Research Analyst, and I will be reading your chats and moderating today. So without further ado, I'll let Kevin do his thing.
Yeah. Sorry about the chat. It was not supposed to be a question mark at the end of welcome back. It's an exclamation point. Different emotional cadence for a different day. Let me pull my slides up here. Um, home stretch, guys. We're connecting the final dots here today. We're going to start with Mr. Stevenson and use one new aspect of his case study to sort of anchor us to the promising practice picture. I'm going to talk more broadly about opioid use disorder, take us down from the receptor level up to the public health level so we can understand how opioid use disorder really functions in this transitional period. And I say that because that's super important. Why is that super important? If you understand the issue from the micro to the macro, you understand more about the issue. When you understand more about the issue, you connect more dots. And that's not just for clinical folks. We've got behavioral health here, we've got case managers, we've got CHWs, we've got a grant writer too. And what do all these folks have in common is more information at the foundational level allows them to do their job at a higher level. So that's the goal. So that's why I'm building that. And also, as far as promising practices go, we're going to sort of anchor the conversation in folks like Mr. Stevenson. This is, of course, a very diverse population, but we're looking at the sickest aspect of it, or the aspect with the highest burden and, of course, the most need. Finally, the paperwork and the process to get your health center so that they're actually able to provide this transitional care. There is a defined HRSA process to expanding your services as a health center. I just want to go over the application with you guys and show you what it means. If you have a correctional institution, state or federal, in your area, which you might not realize you do, by the way. And especially if you live in a well-populated area and there's tons of patients from different walks of life, you might not see them that often. My argument for you will be that potentially poses an opportunity to expand your reach as a health center, build partnerships, and start serving these folks easier, which will help them in a health sense and help your organization from a financial sense. And that's sort of my sweet area that I really like. When we can find things that both help the patient, help the population, and help the health center financially, that's a sweet spot where we can really incentivize folks we can align incentives. So, all right, I digress a bit, but next slide, please. Okay, let's take us up where Mr. Steven was. Short review. Yes. Mr. Stevenson is a 41-year-old male. work from mine here. A 41-year-old male who recently was seen as a health center after 3-year sentence in a state correctional facility. His medical history is significant for hypertension, type 2 diabetes, and a long-standing history of opioid use disorder with multiple past overdoses. We lost the screen there, Jamoke. There it is. Since his last appointment, he has been difficult to contact. There was a missed appointment, if you will remember that from last session. Housing instability and lack of strong communication networks are also present. He was noted to be missing at a 7-day follow-up and later to be contacted by CHW through a relative. And the sort of things to focus on here that are common and navigable. 1 3-year sentence is a long time. The world's changed a lot. Your structure as a person has been totally redefined. I feel like I'm a somewhat structured person. Do you think you're structured, Jamoke? I think everyone on this call probably feels like they're pretty structured people. They have jobs, they live in America. That's how we live our lives, right? Structure provides us with predictability and allows us to focus on the things we do during the day. It's just a key part of adapting as a human in any society. Mr. Stevenson doesn't have that anymore because he was in a correctional facility for 3 years, and his whole life was totally redefined during those 3 years from a structural standpoint. Everything. When he got his medication, when he went to bed, when he exercised, when he went to the bathroom, everything. So he's out. That's great. But whoa, is that a transition? Have you ever lived in a different country before? I know you have, Jamoke. But has anyone ever lived in a different country before as a foreigner? I lived in Haiti for 2 years, and let me tell you, it was wild adapting to little things. Just how the world was different, how you got things differently, where you went to the bathroom, everything. I didn't know these things. Mr. Stevenson is in a somewhat scarier position in that he's going back to his own society, his hometown, and he is feeling that. And I'm telling you that because it connects to the substance use disorder because it's something that folks remember. It's something that gives them a great feeling of calm. Let me tell you, for folks who have worked with with folks that are suffering with addiction, when I was a street medic, we had to have police officers with us in the city I was working with in because there were violent attacks sometimes when you gave people Narcan. Why? They may have been respiratory depression, but it was some of the most pleasure they've ever felt in their lives, and you snapped them out of that. When folks are feeling discomfort, they will seek that comfort. And if they've had that experience and know how it feels, it takes a lot of will to say no to that. So for people like Mr. Stevenson, who is a archetype of a person you will see, um, we got to give him some credit. Right? He missed his appointment, but let me tell you, the guy hasn't relapsed yet. He's trying to keep things together. He is adapting. What that tells me is it's sort of like your time is money, right? So when you use it, you invest it. And this is a person worth investing. So I will say that. Yeah, and like contacting and communication is the thing you need to really put at the forefront. Folks won't have phones. They won't know how to use email. They're going to be hard to contact. It's really easy to start getting frustrated with someone if they don't show up with one appointment, if they don't show up with another, and they're not taking medications. Frustration adds and it acts as a barrier. So understanding is the way to fix that. So build that understanding, you build capacity for care. And that's just a mechanistic way of looking at it. Next slide, please. And we have the two archetypes, path A or path B. Path A, unstructured follow-up. He shows up to the health center, he misses appointments, maybe falls out of care, maybe says someone in care. He sort of bumbles along in and out of care. That's a patient that is lost to follow-up functionally. Even if he's still in the rolls for a while, even if he shows up every 3 years, we'll see him again, maybe after an overdose, God forbid. This is a high ED risk use risk individual. increased risk for overdose, and poor medication compliance. Jamoke, let me ask you, are those ED visits, are they expensive?
Yes, because it shows up in the value-based system.
Yeah, 100%. And you just stole my lecture point. So good for you, but also shame on you at the same time. But good one. There's no script here. You're leading it. But I'm getting to value-based care. Yes. But you have to wait a minute for that. So it's expensive. How expensive is it if, say, someone overdoses?
Very.
Very, yeah. So if this is someone who needs to go to the ICU, we could be talking 30, $40,000. It's a lot of money. It's a brand new car. That's you save for 2 to 3 years and in your best, and you have that, right? That's a down payment. And that's also a bad Tuesday for people. That's how expensive it is. And because of value-based care dynamics, if this person is in your Medicaid population, there are going to be financial implications for your health center. Now, they don't send a bill in the mail, but it affects your value-based care reimbursement. It affects your likelihood of getting awards, and it generally lowers your position of leverage against all of your payers. You lower that, that's a great statistic for your organization. So ED risk isn't just about avoiding a risk for the patient's health. It's a risk for the system and it's a risk for your organization financially. And I'm saying that in a very like brass tacks mechanistic way to get the point across that it's in everyone's interest to lower this. Path A, unstructured follow-up, does the opposite. When you follow path B and you're flexible with your scheduling with these individuals, you have better retention and care, reduce risk trajectory, improve medication compliance, all of these things go down. It's like an algebra equation, or it's like if anyone remembers chemistry from high school, you have to balance things on both sides. There's a balance here. So there's an accounting to it. So the key is that early intervention. And we did okay with Mr. Stevenson here, but we missed a lot of things, if you remember. For example, he's not treated for depression yet. He hasn't seen behavioral health yet, to my knowledge, and he's not seeing a specialist. And we haven't done that yet because that stuff takes time to do. And he's been hard to contact. What be getting into at the end is how you can start that chain of events beforehand by changing your status with HRSA and making relationships with correctional facilities. But we'll get there. Next slide, please. All right, so let's go back to sort of let's go to where we are now. This is all new. Mr. Stevenson, and we're going to do one little part of a visit and then kind of go to the promising practices, and we're on time. Mr. Stevenson presents for a follow-up 3 days after his misappointment and 10 days after he initiated care. His 3 year incarceration in federal prison ended 10 days ago. He was able to attend the appointment. He was unable to attend the appointment. Sorry, typo. Due to a transportation. Oh, sorry. It's not a typo. Excuse me. He was able to attend the appointment due to a transportation voucher provided by his CHW, who also helped him to establish reliable telephone and email communications. During his check-in, the patient notes difficulty navigating his phone, especially emails, and is unsure if his insurance had been approved. Now, you don't know this, Jamoke, but this is my second job after residency. And between medical school and residency, I didn't use email professionally. I just didn't. I'd use it for communications about stuff. Like it was professionally involved, like there's emailing, but in most jobs, email is much more central. And it took me a year to learn how to use Outlook well. Like it took a long time. What do you think he's going through? Same
Confusion.
thing. He hasn't been using email. Like, pick up the app a year, go back in time and then pick up the app now versus a year ago. The things look different. Like, it's hard to navigate things. If he's getting email reminders and they're going to the inbox or they're going to spam, like, uh, he's already overwhelmed. He's not sitting there getting a master's class in the updates of Gmail, right? Be patient with these folks. Because that adaptation is something. Think of the most you've ever had to adapt in your life. I don't know, death of a relative, in childhood, or like going to college in a different part of the country. Um, this is worse. Think about how that felt, and think about how people like him feel. Um, so wanted to get that point across. But the CHW also is on top of things and got that transportation voucher for them. That means that that person asked about his issues, assessed the issues, and addressed one of them. The CHW made this individual show up today. Without that transportation voucher, he probably wouldn't have. So, star, 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 star. The little things make a difference. That one transportation voucher, that can be the difference between life or death. What if he misses it and then he overdoses? A transportation voucher could have saved that life. Big deal, guys. It's a big deal. For those of you who do this for a living, sometimes you can lose sight of that, because you're in your area of expertise. You don't see this stuff. None of us see all of this, but when we connect the dots, we can see it, we can understand the income, the impact. That impact pushes motivation, makes us better, makes us more effective. So, hoorah. Next slide, please. Okay, he's seen by his PCP, who indicates the following in his notes. The patient reports taking his buprenorphine some days with the last dose taken this morning. Good job. 4 milligrams. Reports no opioid use. Also, awesome job. But regular exposures to other taking opioids makes me nervous. Indicates he has not taken any other medications, including his lisinopril and metformin. Oh, those are very important. He has diabetes and hypertension, and like we gave him, like we've got to work on that. Notes persistent stress and irritability, and when asked about symptoms of depression, anxiety, he notes, I don't know. Red flag, red flag. Okay, next slide. From what we know so far, what should be our main areas of follow-up for this visit? How do we address them? Jump on the chat, give me a 1 and 2. What's the main area of focus that pops out for you in your mind as soon as you saw that? And what would you do to address it? Or part of it, or all of it. But let's squeeze these lemons a bit and see what kind of juice we get out. Either that or you're the lemon, Jamoke. Make Jamoke's job easier by giving me a comment. See, they like you. No, I'm gonna put that in my notebook. Leverage Jamoke for participation because everyone likes her. Anyway, so medication management and medication assistance, referral probably the same day. Agreed med management. We're getting to a lot of med management here. Let's go back a slide. And I'll start with Maria. Do you want to tell? Because I know you got your camera on. So I was wondering if you wanted to help us, and I didn't want to dissuade you from using your camera. Maybe I shouldn't have said that,
I
but
know, I'm like, uh-oh.
I was like, everyone just goes black in front of me. Even Jamoke's gone now. No, I'm teasing. But you said medication management, and some of your colleagues seem to agree with you, and I'm not sold yet. Sell it to me.
Well, I mean, I think just talking to him from a PCP perspective would be important to say, hey, you really need to focus in on some of your medications because you do have the high blood pressure, is it the diabetes? I'm not medical that way, but
Hmm.
um,
Diabetes and
and,
hypertension, you're right
yeah.
on track.
Um, now I mean, the exposure to the opioids is very concerning, but um and also the fact that he's taking his, I don't know how you say that word, because again, you per
Buprenorphine.
yeah, what is that? Is that
It's a treatment for opioid use disorder that folks take daily or twice a
okay?
day if they are in a high risk for relapse
Well,
period.
I would definitely like say the positive on, on that, saying that he's taking that, continue to take that, and then focus on, making sure that he does take his other medications so that he can start to feel a little bit more stable, and then follow up with more behavioral health.
Yeah, you're making the right connections here, Maria.
But I'm not
What do
sure.
you what is your role at your health center? I don't want
Um,
to
I'm a
seem like we
I'm a
are our
patient
jobs, but I want to understand what perspective you're coming from.
I'm a patient care coordinator.
Okay, well there it is. You see the connection there between
So
the clinical and the case management. When I'm
yeah.
talking about these things and the medication vouchers in particular, or like the context here, do you see really how independent my world and your world are?
Hmm.
I think a lot of times we realize that may realize, oh, sorry, we don't see each other's world up close and personal. You're not in
Hmm.
the exam room, and I'm not in front of your computer coordinating. So we don't
Hmm.
see each other's world. When we have a better understanding of it, we can connect dots better.
Hmm.
So I can coordinate clinical care knowing that there's actual real people that need to make that stuff happen. And you can coordinate case care, noting that there's real people that need to deal with the implications of your own work. So the more we understand each other, the better we do at our jobs. 100% promise. And I can see that you're making the connection with medical knowledge, right?
Hmm.
One, giving these folks encouragement, 100% you're right on. This guy's doing great. Two, you can do that and still recognize the danger.
Hmm.
Right? It's like being on a dangerous road. Like, wow, you haven't crashed yet, but like it's dangerous road. We might need to turn a left and, get off of the canyon. Uh,
Hmm.
so 100%. And probing deeper in the medications, that's a big priority. You kind of implied this with your conversation, with what you said, and I think you're right about it. But these things, hypertension and metformin, those chronic diseases are diabetes and hypertension are not the priority for him right now. He didn't say that, but I can see from his behavior, right? He's taking his opioid use disorder stuff, though, which means it's at the top of his mind, which means that man is focusing. But these things have not been a priority. It's been 10 days. So, one of our colleagues, Victoria. I'll thank you, Maria, and I'm gonna ask Victoria a question and transition between you. Thank you for what you do. Um, uh, uh, and next time you arrange a transportation voucher, think of me. Think of the patient. Think of Mr. Stevenson. But Victoria, you mentioned that a CHW might be able to fix this. I don't know. What do you think? I'm not sold. What can a CHW do? Does she throw some
She
magic
just,
dust on it? Does she show up with the medication? What happens?
no, she has to trust. She's building the trust. She got him to the
Hmm.
clinic. He's going to listen to her more. A lot of times, physicians or medical providers are viewed as positions of authority, positions of power. Whereas if I've got, let's say, CHW, who could be a peer, who may have been incarcerated previously. Because if I'm going to set up a program where I'm working with incarcerated or formerly incarcerated individuals, I would want to have peers available to be able to work with these folks. And so when you use peers or CHWs, you're going back to saying, "Hey, remember we talked and your goal was to do this. So how are we going to get that back on track?"
100%. I
Gives
like
back the
you
control.
sold it really well. You sold CHWs really well there, Victoria. Victoria, what are you a CHW?
No, but I have been a health education director at a federally qualified health center in addition to my grant writing that I
Oh yes, I remember. You're the grant writer. I was
do.
just about to say that you write some grants about CHW programs because you
I
describe
do.
it very well. I'm not kidding you. The trust aspect in particular, you described them very well. And yeah, if you look back at the history of, say, prison medical experiments, you can understand why people don't trust doctors, right? We don't have a great history with that stuff. If you're looking back 150 years, everything from OBGYN, experimentation on slaves back in the day, Tuskegee, prison experiments. There's a lot of bad history between us and them. And that history sort of implies a difference. And that means something to people. It is embedded in structures. CHWs can be neighbors, they can be peers, and that's important, but also they know how to talk to them. They don't know how to speak the language. I don't know. People speak differently from different parts of the country. I'm from the Northeast. Maybe you can tell. If someone was here from California or Alabama, they'd speak a little differently than me. Well, that's just big country, right? Cultural differences exist within communities too, based on where people live, what they do for a living. And CHWs know that because they are experts in their communities. They can talk to them, they can build trust, they can get them to show up. It's key infrastructure. Um, Next slide, please. Before I get ahead of myself. Um, what should be our main? Oh, we did that. Next slide. Let's address them. So his missed opioid use disorder medication. What are we going to do with this stuff? We have exposure to opioid use, no chronic disease medication use, and mood disturbance and irritability that is complicating all this stuff. Okay, next slide. So, and you guys got to this a little bit. He's taking this most days. He happens to take it today. He's missing doses. We need to probe why. Some hypotheses. Unstructured life and lack of routine makes it difficult to plan something every day. Maybe his sleep cycle is all messed up. There are potential answers there, but getting him to put a foundational thing in his day where he takes his medication at a certain time can provide a structure that he builds the rest of his life on. I mean, it's not great to have to take a medication every day, right? Like people don't like doing that for fun. But he's got to. And if we've got to deal with that, why not use that as something that builds structure within his life? Why, if he doesn't have a routine to take it, looks like he doesn't have a routine with really much of anything. Um, let's help him build a routine with this, and maybe that'll get him into liking routines a little more. Like routines build on top of each other, and like this is one step in a very positive direction. But finding out what that is important. My guess is like lack of structure. So I'm going to really want to know about that and talk to him about engineering his day and motivation so that he can get that every day. Focusing on how much better it makes you feel and how much more functional it leaves you is a great way to start because they will try it and they will see it. And it may take time, but they will get to the point where they adapt. Anyway, so, and confirm the pharmacy. Look on the medical record. Boop, boop, boop. Where's it go? Do you go to CVS on South Main Street? No? Oh, wait, this is a different town. Things like that can make a difference. It happens. It happens. Check the little things. It's like editing a paragraph. You want to make sure you're dotting your I's and your T's, but also check your sentence structure. I don't know. Other big red flag for this patient, exposure to opioid use. Very scary. If you remember, there's folks around him on a daily basis that are using this stuff. It's why he moved out, and now he's living with a friend. Maybe there's exposure there too. Remember this individual was a regular user before he went to federal prison. So my guess is that's possibly in his social network. So that makes me nervous too. Next slide. Sorry. Yeah, next slide. It comes up with the next slide. There's my words. Yeah, so obtain details regarding exposure events. Right now, all we know is that so and so used. We don't even know the individual's name. He said he's exposed to it in a semi-regular way. Why does he say it like that? I don't know. Sometimes people don't like to just tell you who's using opioids, right? Like that's not something you necessarily just bring up in private company. But it's clinically relevant. So probe who's using in front of you. Like, when is it happening? Find the pattern of where this is happening. And this is something that CHWs can do, behavioral health folks can do, clinicians can do, and so forth. It is this, because when you can't fix it if you don't know where it is. Um, so, and I think of sort of the classic CHW coaching dynamic. This is something to work with the patient on. How do we create a structure and a routine that gets you away from those things? Right? Those things happen in the house. You can't go like it's create a structure and a routine that gets them away from it. That's the way to go. And troubleshoot strategies. Yeah, that's what it is. Minimize future exposure. Next slide. No chronic disease medication use. He hasn't taken the stuff at all. Not once. That's a big problem. Hypertension, diabetes, deeply connected to depression. Depression, is that connected to substance use disorder? Yes. When you're very anxious or you're very depressed, you're more motivated to find relief. So these things are all connected, and it's like a staircase. You walk up it. It's an algorithm of just behavioral pull that affects people. Find out what that algorithm is, what gets him to exposure, and how I will. Sorry, find out what that algorithm is and intervene where you can. Things that are high priority, insurance. Like we knew it was pending. If he doesn't have insurance yet, he may not have his medication because of that. It might be a delay. We can check that. That's typically a CHW. We'll check that by calling them directly. Also, you look on your portal. It can give, depending on state or organization, will typically have that information available for a Medicaid plan. It's different everywhere, but my understanding is that's universally there. Um, Phone is a backup if you can't get in the portal. And of course, providing patient education on conditions. When I was talking to you about this, Maria, and I'm not pulling you in again, I promise. But I mentioned that it wasn't a priority for him. The way to fix that is with education, because should hypertension and diabetes be a priority for a rational, adapted person? 100%. So that's something he's acting irrationally and he's acting maladapted. Why? Well, it's a couple reasons. There's a stressor there, and there might be a lack of understanding too. You can't be adapted to something if you don't know about it. So if he doesn't really understand his conditions, maybe they were diagnosed when he was in prison. They're not exactly sending public health educators around from cell to cell. He might not really understand this stuff. So how could you expect him to adapt if he doesn't know? You can't. So that public health education can turn some light bulbs on that change behavior. And, ultimately with folks, you can't follow them home and, here's the pill and here's this, you can't be his dad or his mom, and it can be frustrating because you want to be there with the patient. Like, here, do that. Like, you want them to get fixed. What you can do is you can turn the lights on in the room by giving them that information. It will allow them to see their lives through a new light because it connects dots. And when folks understand how serious things are and that it is connected to his opioid use, it is connected to his overall health and motivation, you might just start to say, oh, this is more of a priority now. That's what you want to do. When you're public health education, when you are public health educating people, you are making them a pitch to change their priorities based on this new product you have called public health education. It's information about your body and your life that you don't know and can make your life better. So sell it. sell the public health education, not just, hypertension is a disease that does this, this, and that. It's caused by high blood pressure. It's like, no, hey, Mr. Stevenson, this hypertension and diabetes, it may not seem like a priority right now, but it is 100% participating in X, Y, and Z, your anxiety, your depression, your lack of structure, and so forth. If we fix these things, you're going to feel better. Here's some information how you can help yourself. Sell it to them. You really need to sell it to them. So I can't emphasize that enough. Yeah, Mary knows. You got to sell it to them. I mean, and like practically, I can tell you because I've sat in this position and been like, how do I convince this person a couple times, many times, and it's sort of you kind of ask yourself what works. So there's different philosophies for doing public health education. I prefer the modern marketing influence part of it because I think it tells us a lot about human behavior. The old school way is just to scare them. I don't think that works. I think the data tells us that doesn't work too. So you can either scare them or motivate them. Let me tell you, if you're going around from room to room scaring people about how Coca-Cola is going to kill them, you're not going to keep patients. They're not going to stick around. But if you're going around from room to room, because you're guilting them, like it's not enjoyable. But if you're going around motivating them, they're going to show up. People like being motivated. It works. Well, and nothing works 100% of the time. I need to say this. You'll do this sometimes you'll do this 5 or 6 times before people will actually change. But when you change, when you reach that threshold, you see the impact. What I can say is keep pushing. Do the public health education, make it big, make it prominent, and make it direct. And they will connect the dots over time. It's a longitudinal relationship. This is an enrolled patient. We see him over time. We educate him over time. He gets better over time. Anyway, next slide, please. Yeah, next slide. Yeah, we haven't screened him for depression yet or referred him. Other things have been taken, and that's on purpose, right? Like I'd love to write this, flowery case study where just everything goes perfect, beep, 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 beep. In order to do that, we would need to transcend space-time, and that's not something that I can put forward realistically as a promising practice. Things get missed, especially at this health center, this hypothetical one. They're catching him at a very vulnerable time and didn't have any time to coordinate with him. Things always get missed in those circumstances. He didn't get a depression screen. So we need to make sure he gets that today, and we need to consider starting medication today. If there's need for a behavioral health appointment, in this case, I'd say yes. It's up to everyone's discretion, of course. There are more questions we need to ask before we can say definitively yes with that. I'm leaning towards a yes. So if that needs to happen, that needs to happen today. The provision of behavioral health resources. Next slide, please. By inconsistently taking his buprenorphine, patients like Mr. Stevens put themselves at risk of relapse through receptor-mediated mechanisms. Okay, so we're going to step back a little bit here. I really want to give an understanding that is visual, because when you understand this stuff visually, it adds context. It allows you to connect dots more, just how the brain works. And when I learn about a topic, I like to learn it from micro to macro. And that's from the small to the big. Because when you understand things like that, it allows you to connect dots in a way that is much more powerful than if you just understand your lane. So I want to do a little talking about just how opioid use disorder works and what the receptor mediated aspects of it are. Jamoke, do you know what the opioid receptor is?
Sorry?
Do you know what the opioid receptor is? It's fine if you don't.
No.
Does anyone know what an opioid receptor is?
Or based on the title or what it's called, the part that accepts the opioid.
Yes,
Amazing.
yes. Did you take Latin in high school? Uh, so that finally paid off. There you go. Um, yes. So the opioid goes into your blood or through your digestive system, or you breathe it and then it goes into your blood. But the end goal is your blood. It is then distributed throughout your body, and blood comes in contact with cells, right? And that those opioid molecules, they attach to something called a receptor. And the receptor is what makes the opioid do its thing from a cellular level. Like it changes transcription, it changes proteins, it releases downstream effects that release endorphins and so forth. Everything about the experience of being on an opioid and that is from the receptor level. It happens because that opioid molecule touches a receptor and makes things happen on the cellular level. Now, with any condition that is receptor mediated, and this one is receptor mediated, but there's lots of them. When that receptor gets stimulated, the cells tells itself, oh, that receptor got stimulated. I need more of them. So it makes more of them. Okay. So if you have one exposure to opioids, then your receptor levels are going to go high. And if you keep doing it regularly, they're going to keep going higher. So after a while, a cell that might just have, a handful of opioid receptors is covered with it. And what happens when those opioid receptors don't get their opioids and they're covering the cell? They start screaming chemically to the cell, saying that we are empty, we are empty, we are empty. And that's the major driving for cravings and for relapse. And that is important to understand because we gave this person buprenorphine. It's a treatment for opioid use disorder. The way it works and the way methadone works too, and other treatment works too, is it gives you a specific safe dose of that molecule so that it can keep those receptors happy, content. When they are content, you are more content. You really start, when you are in a receptor mediated addiction, you start acting like the receptors. They're pushing you around. So when he's on his medication, those receptors are happy. And what we do is we lower dose over time. And because of that, there are gradually over time fewer and fewer receptors on that cell. Fewer and fewer. And after a while, it starts to look normal again. That's where we want to get the patient. So I wanted to get that point across because all these things you notice with behavior, the cycles that people go through of addiction, relapse, and so forth, think of those receptors and how I just described them because they are driving that change. Anyway, next slide, please. This is what they look like. And these things sit like in the cell membrane. Here you can see opioid like molecule inside of them. When that happens, all these chemical responses happen, and there's a communication with the cell that leads to all these other chemical responses, which are you can spend 4 years learning about. Next slide, please. Another sort of example of what it looks like when you color the molecules up. This would be sort of half of this would be in the cell, the part at the top, half of it would be below the cell. Next slide, please. Okay. So next sort of chapter here, let's move forward to data. So I want to look at data a little bit, and I want to talk about the expanding your health center program. Next slide. This is a recent study. It was in Missouri Medicine. It's Missouri based. Next slide. So some details on sort of just the prevalence in the justice involved population in that state, which is roughly approximate for what things are throughout the country. Jail inmates showed a 63.3% drug dependence rate or abuse rate. 62% were overweight or had obesity. 44.3% had a history of mental health disorders. 26.3% had hypertension. 20% had asthma. Jimoke, how common do you think Mr. Stevenson is based on these?
Pretty common.
Yeah, he's super common. And that's why I put this in here. Because you're gonna get, he's built from this data. You're gonna get these people because it's a huge part of this population. So be ready for it. And what I'll say is, when you're ready for it, you can structure. When you can structure, you can take care of things more effectively. Next slide, please. So let's just go over HRSA priorities. We have 13 minutes. Let's go over HRSA priorities and how to expand your health center to provide this care. The priorities for treating the justice involved for HRSA are: one, initiating care pre-release within 90 days strictly for transition planning. Um, Two, maintain full health center control. Do not assume correctional healthcare responsibility. Three, focus on continuity, treatment, initiation, care coordination, and scheduled follow-up. And four, integrate medical care with benefits enrollment and social support linkage. We missed a lot with Mr. Stevenson, and you may ask yourself, wouldn't it be great to get to see him earlier? I think it would be great. Do you think we could fix a lot of problems by maybe being able to follow these guidelines? And this is recommendation for HRSA within this program expansion for health centers that provide healthcare in coordination with correctional facilities, which if you are an FQAC, you can either do or apply to do depending on what your status is. We'll get into that in a second. If we saw this individual before he left the correctional institution, we would have avoided all the pitfalls we had. He would have had insurance. He would have had a referral. His pharmacy, we'd know where it is. He'd be taking the meds and he wouldn't have a 5-day gap. And they'd be able to do additional planning so that maybe he was in housing where there wasn't someone using in front of him all the time. Total game changer. Also, health centers need to turn a profit. They are organizations that run on budgets. That is a reality. For certain health centers, it's a good idea to extend a service like this because it's an extra competency that brings in revenue. I will say that that's a key aspect of making a decision to extend a program like this. But if you have a correctional institution in your county or in an abutting county, it is a potential business line for you, plain and simple. And it's something that you should consider. Next slide, please. I'm trying to speak clinical management and public health language at the same time. So you can add transitional care to your health center services. There is an application you send to HRSA specifically for your change of status. I have the link down here in the bottom for all of the paperwork. I'm going to go through the application in a sec. It's something that some of you should consider or bring up to folks who do consider things like this because they may not be aware. Do you think CEOs always know, or managers or program managers always know that there's a correctional institution 2 counties away? No. They may not know that this is a patient population that could be expanded. They don't communicate with each other, send opportunities to your managers and so forth. They will appreciate it. They'll consider it. Next slide. Here's sort of just to go through the steps, and when you look at the paperwork, this is in much, much greater detail, of course, but I wanted to sort of break it down so you could assess feasibility if you're considering it. So, one, the first way to do this is that you talk to someone at this prison or correctional facility about doing this. You sign something called a memorandum of agreement. And what that is it details the services, responsibility, and areas of control for the facility and you, the health center. A HRSA requirement is that the health center should not be doing the healthcare for the organization, the correctional institution that is their responsibility. The health center should be focusing on transitional planning, getting health insurance, and transitional care post-release. You are not caring for them when they are in prison. That is not your job. And in fact, you have to demonstrate in the memorandum of understanding that the correctional facility will continue to do its work or its job taking care of the patient until they're released. That needs to be verbatim in the letter. Um, that's how you show it. Um, so what I'll say is that's actually very helpful. HRSA did you a huge favor by requiring that because it sort of eliminates the possibility for that responsibility to creep in over time. So it's a great system. So you will have to demonstrate health center control of the care, board approval of, as in the health center board, and how services will be delivered and documented. You then submit something called a change of in scope request to HRSA with the required documentation and approvals. Realistically, if this is something that you wanted to do, you make the relationship. You get the internal clearance to look into it. You make the relationship with the correctional institution. You sign the memorandum of understanding. You get approval from your board, and you go forward with the application. That's the steps. Next slide, please. If you follow the link at the bottom, HRSA shows in great detail how you actually do that. They made this very clean. FYI, those resources are there. Next slide, please. And to sort of look at so there's a promising practice is transitional care. Um, and what I'll say is I put it forward for a reason. And it's because it is really hard to genuinely take care of these folks if you don't have some sort of reach into the prisons. You're going to be paying catch up. It makes things so much easier. If it meets your health center's other needs, it's worth pursuing. And if it's there, of course, it's worth pursuing. The Center for CSJ is the Center for Justice Studies. They have a really great promising practice document. So the first person to contact at carceral, so like, are you talking about at the facility itself or the first? I'm gonna assume you're saying at the facility yourself. I think I don't know. I haven't made this connection before myself, but I can tell you how I would do it is send something to their info email or whatever their publicly listed email is every for contractors and send them an email with an introduction. In that introduction, say, I'm so and so health center. We serve students, patients in your released patients in our area, so on and so forth. We are interested in doing A, B, and C. Could you please give me the contact of whoever deals with contractors or outside business? And that's who you'd want to talk to. How to find that info? You're going to need to poke at them to get it. Another thing is just jump on the phone and call people. Call the front desk and say, "So I'm seeking to do X, Y, and Z. Can you connect me to the right person?" That's how you get through to that. My inclination is that it's going to be very different at every organization in every state. But once you get that contact, the initial contact, use it to get to the right contact. Yeah, so what does this allow you to do? It opens up really a whole new world. And if you follow this document, there are a number of promising practices that range across the spectrum from family reunification early on, working on housing early on. You can foreseeably get someone housing if you have 90 days. You can find him something. If you've got if you've he's already 5 days out, it's a totally different timeline. And let me tell you, if you're managing a case through any capacity and you have to do something immediately versus you have to do it within 90 days, which one do you enjoy doing more? Which is a more enjoyable way to do your work? A constant responding like that, or you have 90 days to plan and get something ready? 90 days is better every time. You give yourself a better workflow. So, when I'm pushing these relationships, like there's a lot of downstream things that you might not realize it really frees up. Um, so that's a point. So implementing family reunification early on has a ton of benefits for the patient, especially people like Mr. Stevenson. Family is closer, family is engaged. Maybe they wouldn't need to worry about someone using in front of Mr. Stevenson if they had a chance to go through a formal reunification process beforehand. These are things that you can push forward if you have that relationship with your local, let's call them institution, correctional institution. It allows you to do so much more. And I'll pitch it from a sales perspective too. If these folks live in your community or the correctional facility is in your community, you're going to need to do it anyway. You're probably the safety net provider in the area. They're probably going to come to you anyway. They're from your community. Would you rather deal with it then or early? And it's not just the work is easier. As I mentioned before, ED risk down, overdose risk down, better compliance to medication, stuff like that. You're going to have to deal with these folks in your community, whether you like it or not. But being able to plan beforehand and allows them to have a better experience. But also, what a huge value-based care advantage to your organization. If you do this with folks and you are avoiding, think if you have 20 people like Mr. Stevenson. Do you know how many ED visits you can skip? That's a huge deal. That has financial implications on your organization. 100%. So this is the reality. We live in a public health system that has overlapping incentives, and we may have opinions about it, but it's the environment in which we function. When we are functioning better within our environment, we are more adaptive. When we are more adaptive as health center employees, our patients are healthier and our organizations are financially healthier. That is a fact. So, relationships, strategic relationships are a huge, huge way to push both of those forward at the same time. That's my personal opinion. And with that, I think I'm going to toss it to you in a second, Jamoke. Thank you all for serving your community, for serving our country. And I say that not because we have military veterans here, but because health centers, federally qualified health centers, are the vanguard of health in this country. It's amazing. You guys are key to the public health system. So thank you for your service.
Thank you.
Thank you, Kevin, and thank you, everyone. We're coming up on the hour, so unfortunately, we don't have much time for Q&A. But our emails are listed at the end of the slideshow. So if you do have any questions that pop up, just go ahead and email us and we'll get to you as soon as possible. This is a reminder to complete our post-evaluation survey, which will come up once this meeting has ended. It lets us know what we're doing right, what we need to work on, how to serve you, and how to keep these TTAs running. So please do.
Be honest, you won't hurt my feelings. I like blunt people. Be blunt. Tell us what you need. Like, what would be better? Like, if you have the time, we'd appreciate it. We listen. Everything you put in, Fide or Jamoke, we will all sit and read it. We take what you say very seriously. Sorry, Jamoke.
Very fine. Here's our contact information. And thank you all so much for joining. And we'll see you at the next TTA. Have a great rest of your day.